The next speaker will be Professor Gyula Acsádi from the Connecticut State Children's Hospital. Can I just mention some personal information with you? We're both taught by George Carpati in Montreal. Actually, he was our boss, and I would be very happy if we could have him present as well. But we basically worked in the same institute in Montreal. Professor Acsádi will speak about what perspectives we have for therapies in neuromuscular diseases, progression in hereditary childhood neuropathies. Thank you very much for inviting me to this excellent conference, and I would like to welcome both the individuals, persons affected by the disease, and the parents and the helpers, care providers. I love coming to conferences where the parents are present because we learn a lot from each other, and I think it's very important that we have as many colleagues, professors, physicians that come that is possible. My slides will be in English, but I will present it in Hungarian. I don't think I have given a presentation in Hungarian for several years now, so I'll apologize for any difficulties I may have. Now, we're talking about CMT first off. And this is just a beautiful oil paintment that people have been thinking that this young woman may have had CMT. She's trying to get over to the farm, but she cannot walk. She was trying to drag her body across the field. She had no walking frame walker. Of course, we don't know exactly the background of this painting, but now we think that that person may have had CMT. Now, Charcot-Marie-Tooth has been named after a French internal medicine physician, Jean-Martin Charcot, who was also training Pierre-Marie, another French physician, and the third person is Howard Henry Tooth, who was a surgeon working in the military, and they used the term amyotrophy. They described this disease. They did not exactly understand that it was damage of nerve fibers. Nicolas Friedrich and Joseph Jules Desjardins and also Sotas were involved in describing the disease. They were not, the disease was not named after them. They were the first to describe some of the varieties and also to do some of the microscopic research initially. Now, we have covered a lot in previous presentations, so I will not delve on some of this basic information. We have peripheral nerves here that can be damaged in two basic ways. Either the myelin sheath could be damaged or the fibers themselves. Now, one of the most important diagnostic tools is checking the node of Ranvier. We want to localize it because a lot of ion channels and protein localizations that are involved here. Now, the axonal and the myelinating conditions, I don't really want to talk too much about this, but initially, historically, we used typically microscopic examinations of the actual tissue, what we call histology, and basically microscopy and cross-sections of tissue samples. And now we have much better diagnostics. For children, typically today, if we can decide what rough idea we have on the causes of the test, then we just go ahead and do the genetic tests and not use any of the traditional methods anymore. Now, Charcot-Marie-Tooth is one of the most common genetic disease in humans. And the reason for this is that chromosome number 17 can have duplications, and that is what we call founding mutation in the total human population. And even though it is the most common in its own category, it is not common. In the U.S., rare disease is 200,000 people or less in a population of about 300 million. I think in Europe it's a different ratio, different definition. We don't know the incidence in childhood, typically because the symptoms often emerge when the child is older or even an adult. We don't really have much information about children affected. We think that about 1/3 of all neuromuscular disorders are probably caused by neuromuscular diseases, by nerve conditions. And my personal experience is that as long as you don't have any treatment, well, CMT usually changes very slowly. When the parents know that they are affected and they see the symptoms of the children, very often it's so light, it's so non-severe that they don't even bother to take the child to a doctor. There's no diagnosis set up. So because of that, we don't really know when the disease typically starts, emerges. And the most reference of patients I get comes from orthopedic physicians. They are the people who meet children that have problems, and they are sent to my clinic. Now, myelin versus axonal damage, usually it's about a split of 50-50%. Now, the basic idea is that the longer the nerve is, the more possible that there is damage. This is why we use the term distal, which just simply means where muscle weakness appears the farthest away point, at the farthest away point from the central nervous system. So pain typically comes from changes of the bone structure of the foot or the hand because of contractions. You also often see tremor, shaking in the muscle affected. As a child, sometimes you find hypotony already when the children are born. They are kind of like rag dolls in a sense. We call them floppy infants. And also, often you find hypertrophy, neuropathy, when your MRI shows that the root of the nerve is more thick than it should be. So most mutations are typically related to PMP22, but not duplication. Instead, it's point mutations, and sometimes other genes are also involved. The most interesting is that the foot structure could be very different from case to case. Pes cavus is the most typical. It appears slowly, and very often it's just a flat sole, basically. And also we have hindfoot varus, which means that your ankle turns towards the outside. And you have also forefoot adductus, which is something that you can identify with pressure testing. We're talking about a plate that your patients step on, and the plate has sensors and tells you where the weight is greater, where the pressure is greater. And this is directly correlated with the type of pain the patient often experiences. Um, we have club foot situations for children. This is not specific, but it happens a lot. And later on, a flat foot can also emerge as an actual symptom of the disease. The biggest problem for CMT patients is walking. How do you test walking? I'm lucky because our Connecticut Children's Hospital has an excellent computerized walking or gait analysis system where you put sensors on the knee, on the ankles, and you record the walking, the gait of the patients, and you can test those and measure those. And you see very specific changes as compared to what we call the normal. The hip may be swinging from right to left. The feet could be rotating in various directions, and you can quantify all those differences fairly nicely. So just to go through the symptoms, distal muscle weakness and imbalance, associated foot and ankle deformities, and typical gait abnormalities. Now, the distribution of CMT cases, CMT1 is demyelinating dominant, CMT2 is axonal dominant, CMTX is cross-linked or X-linked. It happens with CMT3 is severe infantile cases, which we also call the Gerin-Scottus. CMT4 is recessive, and there are also other terms. The recessive could be either a the myelin sheath problem or a nerve sheath issue. Other terms are used. Sometimes these change across the ocean. The US and Europe use different terms, hereditary neuromuscular disease, and so on. Now, if you take a look at CMT1, this is a duplication of the PMP22 peripheral myelin. We're talking about a change in the dosage. There is too much protein being translated, being built by the gene, and it actually damages Schwann cells. Now, point mutations is another situation. These are more minor, affecting the same gene. 1A, nevertheless, can be more severe than the previous version, and it might affect very young children. Like it has been mentioned before, CMT2 involves all sorts of various genes, but the most common is abnormalities in mitofusion number 2. That's about half of all the cases. We have 130 different genes that have been shown to be involved in CMT. Some of them are very rare, and what we see is that they are also involved in other diseases that might affect the brain and skeletal issues. So these genes are not only involved in pure forms of neuropathies, they might be involved in other diseases as well. Now, what is the role of these genes and proteins? It's very varied, it's very diverse, and the functions change in very different ways. The myelin formation is very important. The dissolution of the endoplasmatic reticulum which basically means that the cells get rid of some structures that they don't need, which is a healthy process. But if the proteins are not available, or if there's too much of them, then this is a problem. And just something interesting, maybe today we focus more and more on the synthesis of TR and S. Just 2 weeks ago, there was a rare diseases symposium at our hospital, and one of the prominent professors at Jackson Labs is involved in testing animal models for TR and S synthesis. And based on animal models, he has a plan about how this could be actually used in general for therapeutic purposes. So this is quite an interesting involvement, and I think we will be hearing about this fairly soon in this type of CMT. Now, when we come to the specific diagnosis for CMTs, we have covered this partly. We have the old systems and methods, EMG, for example. We still use it, but not very often. We rely more on genetic panels, and even so, some of our diseases do not have specific diagnosis. Typically, I propose EMG, electrophysiology, when there is suspicion that the differential diagnosis is not exactly accurate. Now, I also have to say that there are two important diseases that you have to recognize because they can be treated. One of them is amyloid damage of the peripheral nerves. There is a specific therapy for this, and the gene panels must include this. And the other disease is Fabry's disease. Right now, I have 4 patients that are X-linked disease affected, and there is an enzyme therapy for this variety of the disease. So that also has to be included in the genetic panels that the geneticists use to test patients for these diseases. Now, how can we prepare for the treatments? The problem is that for a long time we have not been focusing enough on acquiring enough information about our patients because there was no treatment for light cases, non-severe cases. And we did not know how the disease, what the course of the disease is, and we did not have any validated output tests, no validated outcome measures. And I was lucky enough to work together with Mark Shy, who is a prominent neurologist, and he worked in my group. We faced the problem that, okay, even if there are treatments for specific varieties of CMT, we don't know how to find the patients that have that specific variety of CMT. We don't have the outcome measures. We don't have validated ways to specifically identify who this treatment would be good for. So then we started the first outcome measure tests, studies, by measuring muscle strength, and that helped us identify that this disease is not a stable disease. Muscle strength worsens, gets weaker and weaker over time. So we created an adult neuropathy score system. Professor Shy published it back in 2005. Based on the symptoms and the electrode-based testing, signal transmission testing, and then many of this actual CMT system has been used in other adult neuropathy situations as well, but this adult neuropathy score, the CMT-NS, is right now under a major overhaul and revision because it was not specific enough to some of the less rare varieties of these neuromuscular diseases and conditions. So the biggest motor for the driving engine of this research, other than Mark Shai, was Joshua Burns from Australia and Tim Estilov in Philadelphia Children's Hospital. The three of us met several times, and we went through these functions to see what we can actually score. So we created a scoring system for the various, based on the various symptoms. We had to set up statistical proofs for each of these to prove that the system was sensitive enough to changes. We had to come up with a system to score the actual structure of the foot, high, broad, or flat. So we also had to standardize, to come up with standardized tests for testing fine motor skills. We have what we call a 9-hole peg test, and you can actually time the performance of the children putting pegs into holes on a board. And also you can use a myometer to actually manually measure the strength of foot muscles. We have pinprick and other tests, and basically we have a composite scoring system. And I would like to encourage all my colleagues to use the training materials of Inherited Neuropathy Consortium, which tries to standardize how physiotherapists use the treatment options and how they use the actual scoring to make sure that there is some consistency across the international venues of all these cases. We have a CMT PEDS website where you can actually calculate the actual function-related scores. When we first compare children, we could tell that the score is increasing as children age, which means their situation will deteriorate over time. Very recently, we published some phenotypic variability data, which shows that the outcome of the disease varies widely depending on what genetic type of CMT they have. The external two-way is usually worse in terms of outcome. Type 1 is usually not that severe in terms of the final outcome. But I have to say that variability is just all across the board. It's wide, even within the family. It's all over the place. Sometimes some family members have the same condition, but are much more severe than others in the same condition. I have two teenagers that I follow the case of. They have CMT2A and very severe foot weakness, both children. And the mother was unaware of the fact that she had the same disease, but she was a marathon runner. And she never noticed any symptoms. She could not believe she was also affected by the same situation, same disease. All she remembered was she could not go ice skating when she was young child because her feet would not fit into the boots. But then she became a marathon runner, a sports person, nonetheless. So it is a good idea to standardize the test and the scoring systems so we can actually tell whether the medications are effective or not. Now, we only have 2 years worth of data, but in 2 years, other than the variability, you can also see that unfortunately their score does deteriorate within even just 2 years. So if you have a therapeutical intervention At one point, you can identify for a specific individual whether the drug was helping them or not. So that is a major indication why you should use this system. And the more information we collect, the better the reliability of our medication evaluation will be. Now, CMT infant scale is something you can use from age 4. Actually, I need to correct that. The previous system could only be used from age 4, but we needed a different system to score infants and very young children. That's something that was done also by Joshua Byrne and his team based on an international survey. And this score is trying to use reference data from healthy children in terms of motor functions and fine motor functions, describing those functions and scoring them. Now, statistically, this could be validated, and it is under publication, the system, but we don't have enough information in the long run to see to what extent this scoring chart is able to follow the course, the progress of the disease in children, in young children. Now, like I said, our laboratory examines, tests the gait of people. That helps us understand what the problem is in the case of any specific child. We do quantitative tests to see the variance from the normal values. It doesn't only help surveying what the actual deformations are, but it also helps us clearly understand and see, and if you can check that, you have to check that, to see how the pressure patterns change over time on their feet, on their soles. So we can use various parameters and follow in the long run what the deviations, the changes are. It doesn't only help us to see the changes in the child's condition, but also if there's any therapeutical or surgical or maybe orthotic interventions, then their gait can be checked once again, and then we can fine-tune our ideas about what the best surgery would be, what the best orthosis would be. And very often when children are given orthosis solutions, if it's not well designed, it often does not improve the gait of children. Actually, it deteriorates. So if it's not well planned, it doesn't help. It actually makes the situation worse. Now, some gait parameter change graphs on the screen that only emphasizes that over time the situation usually worsens. Now, there has been a lot of attention in the field of biomarkers. If you want to monitor therapies, it's a good idea to identify biomarkers that help you check the situation by systems like MRI, for example, muscle MRI. And Mary Riley's group is in the UK who are doing most of the work in this area. We're talking about muscle, fatty tissue, and connective tissue changes in the ratios between those three types of tissues. And we'll see over time how useful this will end up being in therapy. Also, neurofilaments have been measured when they are released from the myelin sheath. Unfortunately, the testing does not seem to be refined enough. The resolution is not good enough. But in some diseases like spinal muscular atrophy, it is actually useful. Now, we have to find specific treatments for every single type and subtype and subtype of the disease. And typically, it is more difficult to find therapy for dominant forms of the disease because it's much more difficult to block over functions than to rejuvenate under functions or to boost under functions. Actually, the speaker corrects himself, I believe. You can use oligonucleotides to downregulate dominant gene expression, but if you go too far, that will just create a different type of neuropathy. So the fine-tuning of this therapy is highly critical. It may be possible, but it's not easy. Another possibility in the case of a dominant disease is metaphysin. We have two types, type 1 and type 2. Type 2 is the mutated form, and it looks like metaphysin type 1 may have a compensatory role in this disease. So that's another big research angle to try to boost, to upregulate this compound. It may be able to compensate for the missing metaphysin type 2. Now, in the case of recessive conditions, gene editing, gene therapy is a good idea. The problem is these are extremely rare diseases, and you have to find biotech companies, pharmaceutical companies, and sponsors who give you money to do the research. That is definitely a bottleneck. It's a limitation. In the U.S., we have a rare disorder program to sponsor individual researchers to come up with therapies that are only useful for 10 to 15 patients across the U.S. So there are good practices in this sense, but it's obviously a lot slower than the case of diseases that affect a lot of people. Now, gene editing is yet another very important area where the abnormal gene can be normalized or either blocked in a way that it has a therapeutic effect. That's another big effort. Right now in CMT, we do not have any routine theory that is widely accepted or could be considered a proven therapy. We have a lot of efforts going on, obviously mostly for the most common version, CMT1A, involving PMP22 expression. I think there will be a clinical trial coming up fairly soon. Now, we have a phase 3 trial going on for a combination of 3 drugs that have been used for a whole range of other conditions. And the idea comes from certain animal experiments because we see some positive effects, but at the same time, we are not entirely certain about the biological background. Especially in animals, these drug combination, this cocktail of active agents has some positive result, but I'm somewhat afraid that the outcome of this study may not be significant for humans. We have tests being done with human patients older than 16. Gene editing is fairly advanced in animal experiments, animal models. The problem is this is not really easy to do the same thing in humans, especially because of immunological complications. Looks like gene therapy has been becoming more and more efficient and more accepted for recessive and monogenetic monogene related diseases. So I think we will see results fairly soon in those areas. Now, the biology of the disease is something that makes you think a lot. And it brings up problems for a researcher when they want to create a uniform treatment regime. But even though progress is slow, we trust that we will have the possibility to come up with new types of therapy. What is very important, however, is that we need to monitor these cases. We need to learn as much as possible about the various types of the disease to see how the disease runs its course. I am sure that the earlier the intervention takes place, the better it will be. We have to recognize that early diagnosis is your strongest card in this suit, and that's where we need to focus. You've seen this list before. We've seen this in another presentation. It only shows that there are currently tests being run. There is a gene therapy effort going on for the identification of a neurotropic factor that could be expressed non-specifically. In animal panels, we see some positive results, but once again, I'm afraid this will not be very widely used in CMT simply because it does not really have a very prominent effect. So there are two very important studies here. PharmaNext is one of them. The other one is gene therapy trial for gene therapy treatments, and we'll have to see what the result will be over time. I just want to give out a positive message to families and patients, saying that progress is on the way, and we hope that in the next few years we will have specific treatments for various types of CMT.
Nagyon szépen köszönöm.
Thank you so much for this highly informative presentation. I was really happy to see that you spoke about monitoring, and it's important that those affected understand how important monitoring is, because it can give us further opportunities. Before we move on to the next presentation, I'm asking the audience if they have any questions whatsoever to Professor Acsádi. I can't see any hands, but I think after Professor Acsádi's second presentation, you will have a chance to ask questions. And now there's a change in program because instead of Professor Lawrence pre-recorded online presentation, we will have Professor Acsádi's second presentation, because we are afraid if we announce a coffee break now, we will not get